All right, let's jump right into this explainer and build a really structured, high-yield roadmap so you can confidently conquer that floppy infant clinical or development station in your MRC-PCH exam. Listen, if you've ever felt that cold sweat of exam panic when faced with the sheer volume of neurological conditions you have to memorize, you are definitely not alone. But today, we're going to make spinal muscular atrophy, or SMA, incredibly clear and easy to recall. We'll be breaking down the exact history, the examination, the investigation, and the management strategies you need to seamlessly demonstrate to your examiners.
To mirror the exact flow the examiners expect, we're going to cover 1. Defining SMA, 2. History and classifications, 3. The clinical examination, 4. Investigations and complications, and finally, 5. Management and the MDT.
Okay, let's kick things off with Section 1, Defining SMA, the Pathophysiology Foundation.
The absolute most crucial takeaway here is that SMA is fundamentally a disease of lower motor neuron destruction. It's actually the most common inherited motor neuron disease, and it's passed down in an autosomal recessive pattern. You definitely need to memorize that it's caused by a mutation or a deletion of the SMN1 gene, which lives right there on chromosome 5q. Now, this genetic defect leads directly to the degeneration of the anterior horn cells in the spinal cord, and that's what gives us those severe lower motor neuron signs. Keep those anterior horn cells in mind, okay? Because they literally explain almost every single physical symptom we're about to look at.
Moving right along to Section 2, History and Classifications, specifically for the developmental station.
So if you're in the development station, the patient's history and their motor milestones are your immediate roadmap to identifying the exact type of SMA. Notice how the onset time perfectly matches the highest motor milestone the child achieves? It lets you instantly categorize the patient. Let's break it down. Type 1, which is also known as Werdnig-Hoffmann disease, is the most severe. Onset is super early, usually before 6 months, and definitely presenting at less than a year old. These infants suffer from severe weakness and, tragically, will never be able to sit or walk. Then you have Type 2. The onset is a little later, typically between 6 and 18 months. The peak milestone for these kids is sitting. They can sit independently, but they won't ever walk. And finally, Type 3, or Kugelberg-Welander disease. This presents much later, usually after 18 months, or sometimes even between 5 and 15 years of age. These children will actually walk independently at first, but then they experience progressive weakness later on. If you just ask the right questions about when the symptoms started and what the child can do right now, you can confidently tell the examiner exactly which type you're looking at.
Next up is Section 3, the clinical examination, or as I like to call it, spotting the floppy infant.
Step by step, this is exactly how you've got to structure your physical exam. Step 1 is your general observation, right from the end of the bed. You'll notice the hypotonic posture. The child is very often bedridden. But crucially, look at their face. It's usually remarkably bright and alert. Step 2 is your general examination. Look for symmetrical weakness. Check the spine for scoliosis, which is a major complication. Oh, and here's a great examiner's trick. Look closely at the thighs for a tiny little scar. That could indicate a past muscle biopsy. Then, Step 3 is your local neurological exam. You're hunting for those lower motor neuron signs, decreased tone, decreased power, and diminished reflexes, sometimes even total areflexia. And please, don't forget to look inside the mouth for tongue fasciculations. That is a classic hallmark of anterior horn cell disease.
When you're presenting to the examiner, you really want to emphasize these classic clinical features. You're basically describing the quintessential floppy infant. The muscle weakness is symmetric and it's proximal, often with really visible muscle atrophy. Now, because the intercostal muscles are weak, but the diaphragm is relatively spared, you'll see this distinct bell-shaped chest with paradoxical breathing. You're also going to note bulbar weakness, and that leads to a weak cry, a weak suck, poor head control, and some pretty significant feeding difficulties. These are your absolute red flags for severe lower motor neuron and respiratory involvement. Now, this is where it gets really fascinating, and honestly, it's vital for a spot diagnosis. It's the stark contrast in these patients. You have these profound physical deficits, living right alongside completely preserved sensory and cognitive functions. On one hand, profound weakness, hypotonia, areflexia, and atrophy. But on the other, sensation is entirely normal. Extraocular eye movements are perfectly intact, and their cognition is completely unaffected. These children have wonderfully alert, expressive faces. It's this exact mismatch that should make the alarm bell scream SMA in your head.
All right, on to Section 4, Investigations and Complications, confirming the diagnosis and anticipating danger.
Once you suspect SMA and you've presented your findings, you have to confidently rattle off the diagnostic pathway.
Always list genetic testing first. It's the definitive, gold standard investigation to spot that SMN1 gene deletion or mutation on chromosome 5. Historically speaking, and just for completeness, you should mention that an EMG would show denervation and chronic neurogenic changes, and a muscle biopsy would reveal atrophy of the muscle fibers. Remember that thigh scar we talked about looking for earlier? That's why. Plus, investigations like spinal geometry and spirometry are absolutely essential, not for the initial diagnosis, but for monitoring the progression of scoliosis and respiratory compromise over time.
And speaking of compromise, you absolutely must emphasize to the examiner that respiratory failure is the primary cause of mortality in these patients. It is the ultimate danger, and it's what drives the urgency of your entire care plan. Because of their weak respiratory muscles, they suffer from recurrent chest infections and apnea. This profound weakness also leads to orthopedic complications, things like joint contractures, hip dislocations, and progressive scoliosis. Add in poor weight gain from the feeding difficulties and sleep disorders, and you've got a really complex clinical picture that needs a highly coordinated response.
Which brings us perfectly to Section 5, Management and the MDT, your comprehensive care plan. Let's finish strong here. A passing candidate doesn't just stop at the diagnosis. They build a team and they deploy modern treatments. Not too long ago, management for SMA was purely supportive. But today, you absolutely have to mention these incredible, modern disease-modifying therapies. They are completely changing the landscape of this disease. We've got Nusinersen, which is delivered intrathecally. There's Risdiplam, which is an oral medication, and then Onasemnogene abeparvovec, which is literally a groundbreaking gene therapy. Mentioning these shows the examiner that your knowledge is fresh and that you fully grasp the shifting landscape of neuromuscular treatments.
But as we know, medications alone don't cut it. The MRC-PCH heavily scores your ability to utilize a multidisciplinary village. So don't just throw out the acronym MDT. List these specific specialists to score those maximum points. You need a neurologist and geneticist for primary management and family counseling. A respiratory physician is vital for organizing non-invasive ventilation. A dietitian is needed for nutritional support, feeding assistance, or maybe managing a G-tube. Physiotherapy and occupational therapy are essential for maintaining mobility and managing those contractures. And finally, an orthopedic or neurosurgeon is crucial for tackling severe progressive scoliosis.
I'm going to leave you with this ultimate clinical pearl. Burn this formula right into your memory. If you see a child with proximal weakness, severe hypotonia, and areflexia, but they have completely normal sensation and perfectly normal bright cognition, think SMA. But before we wrap up this explainer, I want to leave you with a provocative question to test yourself before exam day. What other neurological conditions can mimic a floppy infant? And what exact signs are you going to use to confidently rule them out when the pressure is on? Keep studying, trust your structure, and you are absolutely going to nail that station.